Very nice introduction. Okay, just a second. All right, I think you can see my screen. Great. And so, yes, I'm going to turn for the next several minutes to some practical applications and challenges from the perspective of those in the trenches and how we're applying some of the very helpful guidance that CDC, CMS, and others have generated and provided to us. I have no disclosures to share with you right now, and I will provide our learning objectives to explore the importance and role of different testing strategies in nursing homes, to review the key elements of a successful implementation of a point of care testing approach in nursing homes, to define how to practically address the possibility of false positives and false negatives, and to share elements of an employee engagement strategy that involves testing and more. Genesis, as we mentioned before, has a national footprint covering 25 states, but we mentioned that. And so I'm sharing that perspective with you, recognizing that there are a wide number of public health jurisdictions among those 25 states, and that has been one of the challenges and complexities in navigating this pandemic. So why are we focusing so much on coronavirus testing? It's assumed, but let's just say it out loud. It's because cohorting based on symptoms or exposures is a flawed strategy. We know now that at least 40% of patients in nursing homes with coronavirus are infectious without having symptoms. And so we can't just be looking around to see who's got symptoms to decide who to cohort. And we can't just be looking around to see who had a high-risk exposure, because if we do that, we're missing cases and we are not optimally controlling or limiting the spread of the virus within the nursing home. We need test results. And so let's go to implications then for what tests should we be using. It's often been said that PCR is the gold standard. But I'll suggest it may not be actually, for some of the reasons we discussed earlier. PCR is exquisitely sensitive for RNA from the virus, perhaps too sensitive, picking up RNA fragments when someone is not actively infected, and when the virus is actually not viable, and when the person is not contagious. And so sensitivity at that level has a cost, and it's not always what we need. And in fact, point of care tests, point of care antigen tests, have a huge practical advantage in terms of having the right level of sensitivity to correspond to infectiousness. And I'll show you a chart on that in a moment, but also an enormous advantage of having results in real time. And getting results in real time is something that hasn't been talked about enough in this debate that's gone back and forth in the last several weeks over PCR versus point of care. I would like you all to remember this as we talk about PCR turnaround times, that a PCR turnaround time of 48 hours, which is being talked about as the goal for PCR turnaround time. That means someone could be spreading the virus in your facility for 2 full days before you know it. And as we know, of course, during the pandemic, we've had turnaround times of 4 days, 6 days. We've experienced that, but even down to 48 hours or 36 hours, someone's spreading the virus before we know it. That's not optimal. What we need is a test that has real-time results and the accuracy that we're looking for. So let's talk a little bit about implementation of point of care antigen testing. It's not that easy, but we all need to figure it out. That's the challenge, right? We know that nursing homes right now are stretched really thin. Leadership, staff, it's a tough time out there. And taking on a big additional burden like setting up a lab in a nursing home may not be the first thing that folks are thinking that they want to do or necessarily are able to do, but we have to. It's what we need to get through this pandemic. So step one is establishing a lab. Every nursing home needs to find a place to have a lab. You can't do it at the bedside. You can't do it at the nursing station or in the hallway. You need a dedicated space that's secure, ventilated, sync access. We look at conference rooms and offices, and sometimes you have to displace other functions, but that is absolutely necessary. Then we need to train and certify the individuals that will be conducting the tests. There are a lot of materials available on the manufacturer websites. We've developed checklists. We do a teach-back method to ensure that folks in the centers understand how to perform the test, because it isn't that simple and training is required. And we do virtual tours so that those who are responsible for doing the test are demonstrating their proficiency using video, using a tablet, for example. They're doing it live over video for members of our team who are charged with certifying a center to ensure that they're doing it properly. Staffing is a very important concern. I know that many people are wondering, what do I need to plan for in terms of hours and time? This is a whole additional responsibility that we never had before in the middle of a pandemic. So we're looking for people, we need people who have experience and who are good at infection control because we're handling hazardous materials, we're handling COVID sometimes. We're looking at a core group of people who have the ability to dedicate time to testing. This is not something that is going to be optimally done by just assigning, let's say, a person on each nursing team to do the test whenever it comes up, and they'll just step aside from their duties for a few minutes to do this. No, that's really not optimal. This requires focus. It requires carefulness, and it requires time. And so we need someone to be stepping out of their roles when they're in a testing function, and they need to be a core group who are skilled and who are doing it regularly. We think it's important for point of care antigen testing also to be available 7 days a week, ideally not only during the day, but also in the evenings, because when we need a result then for the reasons I described earlier. We don't want someone to be spreading the virus for a whole lot of time before we get to the next morning and we can test them again. And finally, let's talk about preparing for the testing volume. How much volume do we anticipate and how many people do we need for how many hours? We have to staff for this. And so during our initial rollouts, and we're still learning about this, this is new, we've been able to get 15 tests done in an hour. We have some indication that we can improve upon that, but we're not quite there yet. But right now we're seeing 15 an hour with a team-based approach. Imagine, if you will, one person is doing the nasal swabs, going from room to room. Another person is going back and forth from those rooms to the lab, wherever that is in the building. And a third person is sitting at the station in the lab, running the tests carefully with absolute attention to detail, one after the other. And by doing that, we can get the highest throughput. And so here are some examples of how we've modeled the staffing requirements. Everyone who's listening today can come up with their own models, but we've looked at it this way. In the columns, we have two different types of facilities. One is a strict long-term care facility, and then the one to the right is a combined facility with short stay and long-term care patients, like your average US nursing home. And the rows show different testing scenarios. The first is how many hours a week that we anticipate to test all new admissions, because we do test new admissions and we test them more than once during that period where they're under observation. Testing symptomatic people, where we need a result right away, and testing high-risk exposures like roommates. So here we have some estimates for hours per week. In the subsequent rows, we have estimates for hours per center-wide sweep. And how often that happens, well, that depends upon the risk and the situation. But that's where we're doing staff screening tests or resident screening tests or point prevalence surveys during an outbreak. And so these are some hour estimates. We're still refining them. This isn't something that I'd say you should all use, but there are ways to model this. And I shared our assumptions at the bottom of the slide. So if those assumptions don't fit to some of the attendees today, you can plug in your own assumptions and come up with your own model. Let's talk about interpreting test results. We did touch upon this a bit during the earlier questions. And I would like to point out that all test results in medicine have to be interpreted with caution based upon the test's accuracy, sensitivity, and specificity, and each patient's likelihood of a positive result. What are the implications for point of care antigen testing? The implications are that we need to understand each patient's likelihood of having COVID as we interpret the results. So let's look at a couple of case examples just to make the point in a very straightforward way. Number one, imagine a patient with low oxygen, fever, cough, and exposure to COVID. If it looks like a duck and smells and quacks like a duck, it's probably a duck. So if the point of care antigen test comes back positive, as Dr. Stone says earlier, believe it. You don't need to do anything else. Okay, it's confirmatory. Whereas if the point of care antigen test comes back negative, that's inconsistent with clinical suspicion. Question it. So this is a really simple way of conveying the concept of pre-test probability to everyone who's involved. Case number two, asymptomatic patient in a center with no COVID outbreak, in a county with low test positivity and low prevalence. If the test is negative, believe it. If the test is positive, question it, because it's inconsistent with clinical suspicion. No different from so many other things we do in medicine. So practically speaking, how do we decide the risk? How do you determine pre-test probability? It requires an assessment that should involve the medical team in the center, the medical director, the providers, the advanced practice providers, and the attending physicians. And this is truly going to ask and require everyone to step up and be part of that interprofessional team. Following up on a questionable result, we talked about sending out a PCR for confirmation, but I also would suggest that a repeat point of care antigen test 24 hours later can be very useful and may at some point eliminate the need for the PCR. because 24 hours later, we see the viral surge in the patient who does have coronavirus, and that can be picked up there. I'm going to show you this chart, which was just published yesterday online by the New England Journal of Medicine. The reference is below. It's a wonderful chart. And I'm going to give credit to Dr. Stefan Gravenstein, who we work with at Brown University, who sketched this out for me in July with marker on a piece of paper. And I've been talking about it with colleagues within our organization since then. It's a very important conceptual model that shows the viral load in an individual patient. And it shows the sensitivity levels for PCR, which is the fine dotted line where it says high analytic sensitivity, and the sensitivity level for something like a point of care antigen, which is the thicker dotted line. And so you can see that there is a window in green, a very, very brief window when someone is just starting to develop their viral surge, where the PCR might pick up a case and show positive, but the antigen test with lesser sensitivity might miss it. But if you check 24 hours later, you're well into the viral surge and you'll pick it up then. And so this is something that we're looking very closely at. But we do like the idea of the antigen test because it catches that infectious window in darker yellow in the middle of this graph. Some washouts, as Dr. Stone says, we need to watch out for sample handling to avoid cross-contamination, sample mix-ups. And so we're looking at test tubes and labels as means of transporting specimens from the bedside to the lab. We need to watch out for delays between sample collection and running the test. And that's very important because the manufacturers will point out and remind us that if there's too much of a delay, it's going to lessen the accuracy of the test. We need to watch out for manufacturer training updates that are posted to the manufacturer websites, and we don't always know if we're not looking. And so one needs to have discipline to keep checking it and to see if something has changed. They won't necessarily let us know. We have to keep looking to find out if the training or even the procedures changed a little bit. I'll say that we need to watch out for sampling people who are symptomatic within the lab, because anytime someone tests positive in the lab grinds to a halt, because you need to do a thorough cleaning of that lab before anyone else can come in. And so symptomatic people need to be tested somewhere else, either patients in their rooms, and if it's staff, I don't know why staff should be symptomatic in the building, but we need to solve for that, not bring them into the lab. And more than one type of device within the facility, because they all have different protocols and it can get confusing for staff. Right now, we have the BD and the Quidel machines, one of them in each of our facilities, like just about every other nursing home in America. And we're now starting to receive, as many of you are, the Abbott BinaxNOW paper test. So we already have 2 solutions in the center. That's going to be hard enough, but what we do not want to do is start mixing and making it more complicated beyond that. I said earlier in response to a question that I'd come back to screening frequency and how to use different testing or data strategies to drive screening frequency. And I will assert to you that the county's test positivity rate, while that is setting the baseline requirement by CMS, it may not be sufficient to determine the screening frequency for staff. And here's why. Staff may live in other counties. It may live in higher risk counties that are not the county that the nursing home's in. And there are other factors related to testing strategies and who's getting tested that can influence the test positivity rate. And so solutions to consider are to supplement the minimum screening frequency. It is okay to screen more often than the minimum requirement and actually do that sometimes at our own expense, but it's important. And it's also important to consider where staff live and to consider other data points beyond just the test positivity rate, like perhaps the 7-day rolling incident rates in the county, which is also publicly available. And so we put both of those together, the county test positivity rate and the rolling incident rate, to determine which of our centers are lower risk and which ones aren't. So remember this, and this is another important takeaway. If you're screening your staff once a month, which is permitted as the minimum frequency by CMS, if you're doing it once a month, it means that more than half of the time you have staff in your building with unknown COVID status. Now that may still be okay because we've risk reduced, but we haven't risk eliminated, right? Because we really don't know if someone was tested 3 weeks ago. We have no idea what their status is today. I'd like to just say a few words about staff engagement, but I'm rapidly running out of time and I'm looking forward to your questions. But staff engagement is so important to everything we're doing during this pandemic. It's important to testing, and it's important to so many other things beyond testing, like PPE use in the center, hand hygiene, physical distancing, whether staff are using face masks and behaving in a low risk way when they're not in the facility. because how they behave when they're not in the facility directly affects the facility's risk of an outbreak. And we need to make sure that they're aware of that. And so we've created a campaign, call it a cultural campaign, called the Be a Hero campaign. And HERO is an acronym that stands for helping colleagues in the moment, encouraging them to do the right thing, reacting to anything that they think is wrong, and everyone opening up themselves to receiving feedback. What this is all about from a messaging standpoint, these are different ways of coming at the issue. It's about see something, say something. So everyone's eyes are looking out for how we can improve infection control in the facilities and how we can improve our overall strategy in the pandemic, but not in a punitive or a critical way, but in a compassionate, supportive, and a collegial way. And the last slide I'll share with you related to engagement is something that I use to kick off all of my broadcasts. Here we go, all of my broadcasts across our organization. And these are PPE selfies. We encourage our colleagues to send in selfies of wearing masks out in the community when they're out and about, and to tell us why they're being so adherent in their private time. And they talk to us about their lives and about their concerns for their families and their concerns for the residents that they care for when they come to work. And we use this to reinforce the importance, because we can't just worry about what's going on in the building. We absolutely have to worry about what's happening outside the building as well. And so I'll stop there, and I'm looking forward to questions.